Давай запускаем после.
Абонентский номер занят.
عذبته. Good D, pancreatic cancer or لو جي لازم نخش. ما بعرف بيني وبينك كانك بتحكي مع حالك.
Абонентский номер
Ну
занят.
давай.
Пожалуйста, даже...
Да, алло.
Алло,
Да.
я вас запустил, уже вы уже в эфире.
А, когда закончу, остановить, да?
Да, надо будет остановить трансляцию.
А потом следующее тогда лекцию посмотрим. Хорошо, спасибо.
Не-не-не, когда у вас лекция закончится, вы просто микрофон, там, чтобы красный значочек был, чтобы у вас перерыв, вы же будете делать небольшой для себя?
Нет, я думаю, мы прочтем одну и вторую, там маленькие две лекции по-быстрому, да и все, я думаю. Без
понял. Ну,
перерыва.
тогда будете переключать, позвоните, вдруг я вам тоже могу помочь.
Хорошо, спасибо большое, ага.
Хорошо.
Спасибо. Так. Good day. Our lectures today is pancreatic cancer and liver cancer. So, risk factors. First is consumption of alcoholic beverage, smoking, fatty and spicy foods, diabetes mellitus, cirrhosis of liver. Precancer disease of pancreas. The first is adenoma of pancreas, chronic pancreatitis, and cysts of pancreas. Localization of cancer of pancreas. Pancreas behind 65%, ampulla of water 12.7%, extrahepatic bile ducts behind 11%, gallbladder 7.3%, duodenum 3.5% of patients. Extrahepatic ducts, it means common bile duct or left and right bile duct. No, anatomy of pancreas. When we will discuss the diagnosis of cancer of pancreas, it's more important to know. But from the beginning, I told you that if the tumor invasive to two main vessels, mesenterica artery, mesenterica superior, and vein, mesenterica superior vein. It's very important when we do diagnostics of cancer of pancreas, particularly for head of pancreas or neck of pancreas. Tumor invades the head of pancreas, the most common, behind 50 to 60% of all cases. The body of pancreas behind 10% of cases. The tail 5 to 8% of cases. Complete lesion of the pancreas 20 to 35% of cases. Histological classification of cancer, of pancreatic cancer. First, adenocarcinoma, squamous cell carcinoma, cyst adenocarcinoma, acinar cell carcinoma, and undifferentiated carcinoma. 5 histological type of cancer of pancreas. Metastasis. Lymphatic metastasis of pancreatic cancer has got 4 stages. The first stage affects the pancreatoduodenal lymph nodes, or other words we told, near the head of the pancreas. The second stage affects the retrapyloric and hepatoduodenal lymph nodes. The third stage, the celiac and superior mesenteric lymph nodes. The fourth stage, retroperitoneal or we told para-aortic lymph nodes, retroperitoneal or para-aortic lymph nodes metastasis. Hematogenous metastasis, distant to other organs, or we told distant metastasis, to the face, to the liver, lungs, kidneys, and bones. Furthermore, there is an implantation of tumor cells via the peritoneum, or told contact metastasis. When we do diagnostics of cancer, it is very important to know which stage of lymph node metastasis affected, or if there are hematogenous metastasis, or if there are distant metastasis, other word, to which organ, or if there are contact metastasis on peritoneum, or we told cancerogenesis, canceromatosis. Clinical classification. Mean TNM classification. TX, not enough information to assess the primary tumor. T0, the primary tumor is not defined. TS, it means carcinoma in situ. In situ, what means in situ? When we told carcinoma in situ, it means that the tumor in very early stage and the cancer or carcinoma is not invasive through the epithelium. If the carcinoma is not invasive through the epithelium, we told carcinoma in situ. T1, the tumor is within the pancreas, divided T1A and T1B. T1A, the tumor is less than 2 centimeters in greatest diameter. T1B the tumor is greater than 2 centimeter in greatest diameter. T2, tumor invades one of the T2 tumor invades one of the neighboring organs, invasive to adjacent organ, likely duodenum, bile duct, common bile duct, it means, or the tissue around the pancreas. T3, tumor invades one of the neighboring organs, stomach, spleen, colon. Colon means the most common transversus or ascending part of colon, or liver angle part of colon. Closely spaced large vessels. We put T3 in TNM classification. NX, lymph nodes, metastasis. NX, not enough information to assess the regional lymph nodes. In 0, regional lymph nodes are not affected. In 1, regional lymph nodes are affected. M, distant metastasis. MX, not enough information to assess distant metastasis. M0, distant metastasis are not detected. And the M1, there are distant metastasis or distant metastasis found. Stage, there are 4 stages. Stage 1, tumor. No, stage 1 means T1, N0, M0, or T2, N0, M0. Stage 2, T3, N0, M0, T2, N0, M0. Stage 3, any T, N1, lymph nodes. Stage 4, any T, any N, M1, distant metastasis. Clinical features. The clinical features on patient with pancreatic cancer, depending on localization of the tumor, on which part of the pancreas or extrahepatic, yes, extra ducts. Mechanical jaundice, the first, due to invasion or compression of bile ducts, and the most common mechanical jaundice, the first symptom in cancer of head of pancreas, depending on localization of the tumor on which part of pancreas. The first symptom in cancer of head of pancreas is mechanical jaundice before any symptoms. The first symptom is mechanical jaundice. Courvoisier's sign or Courvoisier's symptom, it means palpable, painless, enlarged gallbladder appear in case of tumor localization in head of pancreas. We told that Courvoisier symptom is positive when we palpate the gallbladder if patient had mechanical jaundice and the tumor in head of pancreas. We can palpate enlarged gallbladder without any pain. Pain in cancer pancreatic head is constant and dull due to stretching of liver capsule appear in right epigastrium. Cancer of the body and tail of pancreas accompanied by pain which may radiate to the back due to invasion to solar plexus. Tumor invasion of the stomach and transverse colon leads to their obstruction, and the most common localization is tumor of the body and tail of the pancreas. If invasive to stomach, maybe leads in the future to obstruction, and the patient had stenosis on stomach. The symptoms will be vomiting, or if the tumor invasive to transverse colon and lead to the future obstruction, the patient will have intestinal obstruction. There may bleeding from the affected organs. General symptoms. Cancer intoxication, anorexia, weight loss, fatigue. General symptoms, including 4 symptoms. Diagnostics. Ultrasound, very good method of diagnostics, not expensive method. CT scan with contrast or MRI, magnetic resonance tomography, with contrast, just with contrast, because more clearly imaging, just more better with contrast. Contrast X-ray of stomach and duodenum. Next, a CT scan with contrast here to exclude, as we told from the beginning, if the tumor invasive to minor vessels or no. It's very important to know if we can do operation or no for this patient before our operation. It is important when we do CT scan or MRI with contrast to see if the tumor invasive to minor vessels. Minor vessels, as we told, artery mesenteric superior and and vein. Superior mesenteric vein. Contrast X-ray of stomach and duodenum, feeling defect in case of invasion of these organs. As we told, if the tumor invasive to stomach or to transversus colon or to duodenum, yes, we need to do contrast X-ray to exclude or include if there are defects. Endoscopic retrograde cholangiopancreatography for assessment of bile duct and morphological verification. Endoscopic ultrasound, laparoscopy or laparotomy with biopsy. No, as we told about hematogeneously spreading the metastasis, or if we suspicion that there are canceromatosis in peritoneum, we can do diagnostic laparoscopy or laparotomy with biopsy. If we suspicion that there are metastasis, canceromatosis, to put finally diagnosis, we can do diagnostic laparoscopy. CA cancer antigen 19-9 and angiography, the same angiography, to exclude if the tumor invasive to minor vessels or no. Now, as you see on the film, compression of stomach posterior wall by tumor of head of pancreas. Invasion of stomach wall by pancreatic cancer. Invasion of duodenum wall by cancer of head of pancreas. Is here duodenum wall. CT scan showing a normal pancreas. What here? The normal pancreas. Mass in pancreatic tile, liver nodules ascites. No, it's liver nodules, Yes. Entile of head of pancreas, and ascites. This is ascites. No, it means that the cancer of pancreatic tile with metastasis in liver and ascites as complication. X-ray examination of the stomach and duodenum. X-ray of the stomach and duodenum in cancer of the pancreatic head. Descending part of duodenum extended has irregular contours. The first, there is indentation outside by enlargement gallbladder. No, 1 and 2. Percutaneous transhepatic cholangiography. Under control of ultrasound. The method is used to identify the level of obstruction. Obstruction what? Obstruction the bile ducts. To know or identify the level if it is on distal part of common bile duct or middle part of common bile duct or bifurcation of left and right common bile duct or intrahepatic level. Yes, if it is to distal part of common bile duct, it means that the tumor in head of pancreas just invasive to distal part of common bile duct. If the level is upper the bifurcation of left and right bile duct, it means the tumor is big in size and must drain the bile through the cutaneous drain of intrahepatic ducts. X-ray feature in the presence is the presence of a full block and circular or semicircular stump with irregular and distinct contours. No, percutaneous transhepatic cholangiography. Here, a tumor of common bile duct here. Now we see the block is here. And in tumor of ampulla of Vateroy Sasuk. What? Разница. It is different operation will be depending on level of obstruction. It is very important to know the level of obstruction. External drain of the bile ducts of the left lobe of the liver. As I told now, external drain, transcutaneous drain of intrahepatic ducts. And here we find the more widely duct, and we will do drain under control of ultrasound. And here, what put the drain. Pancreatic cholangiogram, cancer of the pancreatic head, block of the pancreatic and common bile duct. Pancreatic cholangiogram, cancer of the pancreatic head, stenosis of the main pancreatic and common bile duct. That here is blocked. What is the cancer? Here is blocked. No. Cancer of pancreas. The additional method which helps to put the diagnosis of pancreatic cancer today is tumor marker cancer antigen 19-9. Manifold increasing of this marker in blood indicates the development of cancer of the pancreas. Last time is this additional method is necessary and including as standard additional method on pancreatic cancer. We must do it as is standard of additional method. Radio is a top method with X-ray scan, 3-octreotide somatostation analogy with radioactivity is used in the diagnosis of neuroendocrine tumor of the pancreas. Treatment. Methods of treatment. The stage 1, which including T1 in 0M0 or T2 in 0M0, method of treatment is radical surgery, surgical. Second and third stage, as we discussed before, including T3 in 0M0 or third stage, NET in 1M0. Three method of treatment, combinations method. The first is surgical. After surgical, adjuvant chemotherapy. And the last method is radiotherapy, told combination, surgical, chemotherapy, and radiotherapy. The stage 3 any T N1 N2 M0, excuse me here mistake, N2 M0, palliative or symptomatic. Surgical treatment in third and fourth stage. Palliative or symptomatic surgical treatment. What mean palliative? Before we discuss palliative, just to liquidate the complication of the tumor. In this case, the first complication will be jaundice. We don't do radical operation to remove the tumor. Just here we do palliative operation to liquidate the complication of the tumor. As we told, the first is jaundice, or if the tumor invasive to stomach or transversus, colon, and the complication is stenosis. Here we must do bypass anastomosis or liquidated the jaundice. And symptomatic treatment, palliative chemotherapy. Most common operations in case of pancreatic cancer, depending the same on localization of the tumor. On head of pancreas, we do Whipple operation. Whipple operation including the head of pancreas, duodenum, distal part of common bile duct, and part of stomach. Distal resection of pancreas if the localization on tail or body of pancreas. We do distal resection of pancreas. Pancreatectomy, total pancreatectomy, and cholecystectomy iona anastomosis. Cholecystectomy iona anastomosis, just anastomosis, we told bypass anastomosis. If the patient had cancer of head of pancreas with complication jaundice and Courvoisier symptom is positive, yes, it means we palpate gallbladder. In this case, we must liquidate the jaundice. It is mechanical jaundice. We do anastomosis duodenum with gallbladder. Bypass anastomosis. Tot cholecystectomy iona anastomosis. Bile drainage, as we told, if the tumor or the level of blockade upper the bifurcation, left and right bile duct, we under control of ultrasound transcutaneous drain, external drain of hepatic bile duct, bile drain. Medicine of chemotherapy, fluorouracil, doxorubicin, metamycin, calcium folinate, and gemcitabine. History of pancreatic cancer surgery. First removal, a sole tumor of the body and tail of the pancreas, produced Trendelenburg in 1082, Friedrich Trendelenburg. First pancreatectomy performed Theodor Pellerat after 10 years after Trendelenburg, after resection of pancreas. total pancreatectomy, margin of our resection, пожалуйста. Pancreatoduodenectomy, Whipple's operation, including head of pancreas, duodenum, part of stomach, and distal part of common bile duct. Here is we leave tail and body of pancreas. We told Whipple operation or pancreatoduodenectomy. Plastic endoprothesis in case of carcinoma of ampulla of Vatera. Prognosis, the outlook is extremely poor. Pancreatoduodenectomy is associated with significant operative mortality. The 5-year survival in case of resection for carcinoma of ampulla of Vatera is 40%, while in case of resection for tumor in the head of pancreas is only 20%. The overall survival is 20 weeks, and the 5-year survival of either of the tumors is less than 3%. The same depending on stage of the patient, but usually patient a patient had the first symptoms with jaundice or stenosis. And usually patient come to doctor with already second stage. Already with second stage when the patient had jaundice. Хорошо. Thank you. Wait a minute, please. Wait a minute, please. Wait a minute, please. Praise what? Wait, please. Other lecture. Just 2 minutes, please.
Абонентский номер занят. Пожалуйста, дождитесь.
Just 2 minutes, please. Не знаю. Please, 2 minutes. Да, алло. Да, я вторую включил, посмотрите, я правильно уже иду.
А вот настройка слайд-шоу нажмите, пожалуйста, вот у вас кнопочка есть.
Какая?
Настройка слайд-шоу. Вы правильно открыли презентацию, и вот настройка слайд-шоу такая...
Да, я нажал управляемый пользователем, да?
Ну, теперь только с начала слайда, вот нажмите кнопку.
Слайд?
Да, с начала слайда, вот самая первая кнопка здесь.
Сейчас, подождите. Настройка слайда, правильно?
Да, вот теперь самая первая кнопка под надписью «Файл» находится, вот, увидите. Левее, в самом левом, в левой стороне такой вот значок презентации с значком play таким зеленым вроде.
Не, сейчас, подождите, я что-то путаюсь. Где на... Вот это?
Ну, вот ниже, курсор чуть-чуть ниже. Задержка. Слайд-шоу. Вот, да, сначала. Вот, нажимайте.
Ну, слайд-шоу, правильно?
Да.
Дальше настройка?
Не, вы уже там все сделали. Вы сказали, вы поставили управляемый пользователь.
Да, дальше что? Вот этот нажать?
F5 на клавиатуре нажмите.
Какая?
F5.
F5, все, понял.
Да. Сейчас я увижу.
Установить.
Получилось у вас, да?
Установить защиту от неизвестного содержимого рекомендуется.
Ну да.
Окей.
Не, снизу галочку ставьте. Нет, у вас, видимо, какие-то там есть файлы, которые вы добавляли, которые имеют...
Ладно,
ссылку.
выхожу заново, нет?
Не, все нормально, у вас все работает хорошо. Я вот вижу, у вас презентация запустилась в полнокамерном режиме.
Ага, все хорошо. Вы скажите, там много их?
Было где-то около 25 человек.
Хорошо.
Сейчас 19.
Ну, хорошо тоже. Спасибо, все, тогда мы дальше продолжаем.
Хорошо.
So, excuse me, please. We continue our lecture. Carcinoma of liver. Carcinoma of the liver. Anatomy of the liver. Intrahepatic bile duct, right lobe, left lobe, intrahepatic bile duct, hepatic vein, falciform ligament, hepatic duct, gallbladder. Because the same as we told now about pancreas, it is important to know delocalization of the tumor, and the same in liver. It is important to know the histological type of the tumor of liver cancer, and to know the histological type of the liver cancer, the first, and next the localization of the tumor, in which lobe, right or left, and the segment. It is very important. No, yes, in here in Russian language, Lana. Vena porta, left and right, vena cava inferior, and liver. Carcinoma of the liver. It's for you very good slide, very important slide, I told. Why you can't remember it? Carcinoma of the liver. We told about cancer of the liver. Remember, please. It is very important. Please. We told primary cancer of the liver and secondary cancer of the liver. Primary. We told a primary cancer of the liver. Secondary, if there are metastases in the liver from other organs. We told secondary or metastatic carcinoma. Primary cancer of the liver divided to two types: hepatocellular carcinoma and cholangiocarcinoma. Hepatocellular carcinoma. No. What histological type? Hepatocellular carcinoma. You see the image after removed of the tumor of the liver. Here is secondary metastasis on the liver. Secondary metastasis. It's secondary metastasis. 1, 2, 3, 4, 5. Multiple different size on the liver and both of lobes, right and left lobe, different from the other organ. 19% of primary liver cancer is hepatocellular carcinoma. Epidemiology. Primary liver cancer take the sixth place in the structure of oncological morbidity among all other cases of cancer. 5 and 7% from all cancers. The ratio of cases to the dead is 0.95 in the USA, 0.87. The highest morbidity and mortality observed in Africa and Southeast Asia. China accounts for 55% of all cases. Etiology. The first, viral factors. Epidemiological studies have found a mirror match areas endemic for hepatitis B and hepatocellular carcinoma associated with hepatitis B. In Southeast Asia and East Africa, carry the virus are up to 20% of the population. Chronic viral hepatic infection. HPV infection, hepatitis C infection, and V infection, congenital liver disease, hereditary hemochromatosis, deficiency of alpha 1 antitrypsin, tyrosinemia, environmental factors, oral contraceptives, steroid hormones, smoking, aflatoxin. Cirrhosis, obesity, diabetes, expensive growth, form of growth of hepatocellular carcinoma, expensive growth, encapsulated tumor growth, compressing the surrounding liver parenchyma, nodular or pseudonodular, multifocal. It means in many segments of the liver, combined, including the elements and expensive and nodular growth, compound growth, fibra laminar registered in young woman, combination of hepatocellular carcinoma and cholangiocellular carcinoma, commonly observed in cirrhotic liver intact. Cirrhosis, more common in men. TNM classification. TNM classification. T1 solitary node, solitary one node, just solitary node, 2 centimeter or less in Grace diameter without vascular invasion. T2 solitary node 2 centimeter or less in the Grace diameter with vascular invasion, or multiple tumor which are located in one lobe less than 2 centimeter without vascular invasion, or one solitary node more than 2 centimeter in diameter without vascular invasion. T3 solitary node more than 2 centimeter in greatest diameter with vascular invasion, or multiple tumors which are located in one lobe less than 2 centimeter with vascular invasion, or multiple tumors in one lobe more than 2 centimeter in diameter with vascular invasion and without it. T4 multiple tumors in more than one lobe, or tumors involving the portal or hepatic vein, minor vessels, or tumor with direct invasion to adjacent organs, or tumors involving the visceral peritoneum. Lymph node metastasis. N1 or N0, there are no lymph node metastasis, or N1 metastasis in regional lymph nodes, hepatoduodenal ligament. M metastasis, distant metastasis. M0 no distant metastasis. M1 distant metastasis. Stage 1 T1 in 0 M0, stage 2 T2 in 0 M0, stage 3 T1 in 1 M0, or T2 in 1 M0, or T3 in 0 M0. Stage 4 divided to stage 4A and B. Stage 4A T4 in 0 M0, T4 you remember we told about what? Invasive to adjacent organs or to minor vessels. Stage 4B any T N1 M1 with distant metastasis. Cholangiocellular carcinoma. Cholangiocellular carcinoma is a malignant tumor which grows from the epithelium of the bile duct. Synonymous with this concept are cholangiocarcinoma. Cholangiocellular carcinoma, or cancer, relatively rare disease, occurring with a frequency of less than 2% of all malignancies. The detection rate of cholangiocarcinoma is 1 to 2 people per 100,000 population. It is much higher in the countries of Southeast Asia due to endemic chronic parasitic processes of the liver. Cholangiocellular carcinoma is divided into intra and extrahepatic. Intrahepatic lesion is found in 10 to 25% of cases. Intrahepatic. According to the form of growth, cholangiocellular cancer is divided into 4 types: infiltrative type, polypoid type, exophytic type, and mixed. In 90 to 95% cholangiocellular carcinoma represents adenocarcinomas, minorly highly differentiated adenocarcinoma. Risk factors. Primary sclerosing cholangitis, choledocholitis and hepatolithiasis, biliodigestive anastomosis, non-specific ulcerative colitis, adenomas of hepatochelitis, multiple papillomatosis, congenital cyst of the common bile duct, Caroli's disease, Crohn's disease, contact with radioactive thorium dioxide, parasitic invasion of colorecsensis E and obstructs viverini, smoking and associated with hepatitis C, HIV infection, liver cirrhosis, diabetes mellitus. Diagnostics: physical examination, laboratory testing, cancer antigen 19-9, cancer cancer imperial antigen, alpha fetoprotein, SHD and FDD, CT scan of the liver in the arterial phase, the retroperitoneal space, consultation, cancer surgeon, physician, and chemotherapist, radiologist. HPSH, HIV, RV, group and RH factor, ultrasounds of liver, chest radiography, endoscopy, fine needle aspiration biopsy of the tumor under control of ultrasound, or trypan biopsy under control of ultrasound. The main clinical manifestation of cholangiocarcinoma is obstructive jaundice caused by obstruction of the bile ducts. Characteristics features of this syndrome is the dependence of the manifestations on the localization of the tumor process. If the tumor is located higher in bile ducts, the date of its manifestation later, and tumor is bigger. And as we discussed before, it is important to know the level of obstruction. The level, it is important. Extra, intrahepatic. Note, jaundice, patient with jaundice. Severe pain is not typical manifestation for cholangiocellular cancer. However, when secondary infection joined and the tumor located in the distal hepatochelitis, acute cholangitis may develop. It is characterized by chills, fever, pain in the right hypochondrium. Advanced form of the disease show signs of cancer, intoxication as pain, fatigue, malaise, and weight loss. Courvoisier symptom appears in case of distal lesions with intact cystic duct. Increased AST and ALT, gamma glutamyl, hyperbilirubinemia, mainly due to the direct fraction. Usually if the hyperbilirubinemia, if it is due to the direct fraction, it means mechanical jaundice, usually. If due to the indirect, it means is not mechanical jaundice, it means infection, the most common. Increase in the level alkaline phosphatase, prolonged obstruction of the common bile duct may lead to deficiency of fat soluble vitamins, anticoagulation, hypo and dysproteinemia. Now what here widely right lobe duct intrahepatic widely intrahepatic duct right lobe. The same left. Tumor invades in surrounding organs frequently. More often it is hepatic artery or pancreas. The most important method of diagnosis of cholangiocarcinoma cell carcinoma and their resectability are direct method of staining of the bile ducts, endoscopic retrograde cholangiopancreatography. Percutaneous transhepatic cholangiography under control of ultrasound. Cholecystic cholangiography. Here, tumor of right hepatic duct, tumor of common bile duct. We see here the level of obstruction. Fistula cholangiography, and here see obstruction. CT scan of infiltrative intrahepatic cholangiography. We see what infiltrative 4 and more than one lobe invasive. Multiple or multifocal lesion of liver, metastasis on liver, the first, or primary multiple nodes on the liver, primary cancer of the liver, multiple. And here we must do differential diagnosis between if it is primary liver cancer or secondary from other organs, because multiple nodes. This same films at the tumor, please. Microscopic investigation, adenoma. Metastatic lesions, what? Or this is metastasis, multiple metastasis. Hepatocellular carcinoma after lobectomy. Cholangiocellular carcinoma. Carcinoma of the liver. The same treatment in hepatocellular carcinoma and cholangiocellular carcinoma. Treatment: surgical excision, radiotherapy, and chemotherapy. Method of treatment: TNC 20M0 or T1N0M0. T2N0M0 is surgical methods. Stage 3 for A, stage 3 T1 to T3 N0 N1 M0 surgical with adjuvant chemotherapy and radiotherapy. T4A N0 N1 M0, the same surgical adjuvant chemotherapy, radiation, radiotherapy. Or if it is not resectable, we do palliative and symptomatic treatment. Palliative treatment chemotherapy palliative, and radiotherapy. Palliative chemo radiotherapy. Or stage 3A and stage 3B. List of operations: left lobectomy, if the tumor localization in left lobe, removing of second and third segments. Left hemihepatectomy, removing of 1 to 4 segments. Right hemihepatectomy, removing 5 to 8 segments. Yes, here depending on localization of the tumor. If the tumor localized in first segment or second or one more than one segment. And the same right hemihepatectomy if the tumor localization in right lobe or segment 5 to 8. Extending right hemihepatectomy, removing from 4 to 8 segments. Atypical resection. Atypical resection if the tumor is secondary tumor in one segment. We can do just remove segment. Catheterization of intrahepatic arteries for chemotherapy. Embolization of intrahepatic arteries. Cryoablation. Hyperthermic destruction. Drain of bile duct. Surgical excision. According to some authors, component of the liver transplantation with radio and chemotherapy provides 80% 5-year survival rate. So, thank you very much. Good luck. Thank you. Goodbye. See you in our departments. Thank you.